So I'm an orthopedic surgeon. I spent 25 years in the Army. Was at Walter Reed, chief orthopedics, and ran the amputee clinic there when I was there. And then I spent 25 years in academia, both UT Southwestern in Dallas and at the University of Florida. And so I think the three lasting legacies of this war in Ukraine is going to be the issues of amputees, the issues of infections, which we've already heard about, and also the issues of traumatic brain injuries and PTSD and mental health, and all of those needs. So it's terrible when somebody loses a limb, and I think the job of any nation is to care for the warriors of their country and to provide the limb, to get them back as rapidly as possible back into their lives. And so as an amputation surgeon, and I spent a third of my life doing, a third of my practice was in cancer surgery, another third was in infections, and another third was in amputation surgery. Most often doing revisions rather than primary amputations, because, and I teach a lot about amputation surgery. It's an easy operation to do, and it goes back to the time of Hippocrates. But it's a hard operation to do well. And I think this is also another one of our challenges as I've been through the hospitals and met with my surgeons and been in the operating room in Ukraine. And in the words of my prosthetist, who's the best I've worked with in years over my career, you give me a good limb and I can get you a good prosthesis. Give me a bad limb and it's going to be impossible to really fit that. And so one of the questions that I have for our panel is, what is the incidence of revision of amputations in Ukraine when they present to the prosthetist? How many of them do you have difficulty fitting a prosthesis, or if there are anatomic issues with it or pain? Can you speak about that, each of you? VASYL, any comments on the?
First of all, if you talk about the number of amputations in Ukraine, due to war, we have less than 10,000 amputees in the military personnel. If somebody can listen about some 100, etc., it's not true. Less than 10,000 during all the full-scale invasion. So the problem with amputees, if we compare the problem with like antibiotic resistance, infection control, and treatment with patient with traumatic brain injury, etc., is not a so huge problem in amputees. But we still have problem of multiply operation which performed in our hospital due to also antibiotic resistance. Also, when some surgeon not enough qualified, was mentioned, Alexander Linchevsky, perform amputees, and some prosthesis tried to fit prosthesis, and patient have some difficulties, and this patient come back to surgery. And in this case, we try to establish some like roles, but often patient have not only amputees, but more complex trauma, and they go to the hospital, which can manage with more dangerous and light treating trauma. But in this hospital, we can, in the hospital, traumatologists or surgeons are not so qualified to perform amputees.
David, could you tell us what your experience is with dealing with discussing patient issues with surgeons? We're just such a lovable bunch, and we're so easy to get along with. Are you picking that up, David?
Yeah, I'm sorry. I just sent a chat in because I just unfortunately arrived at my location and I'll be switching back on to another Wi-Fi. So can you hold that question for about 5 minutes and then I'll come
Certainly,
back?
certainly.
All right, sorry about that.
Thank you. Going back, what is the coordination with Protez Hub? What's the relationship between the Protez Hub and Protez Foundation?
There isn't any relationship, so to speak. Protez Hub is more of an initiative that's not fitting the patients. We are working on systemic changes rather than on focusing on specific number of patients to fit. And this is why we never provide the number of patients that we fitted as part of the trainings that we have developed and conducted, because even though there are close to 1,000 patients now, for us, our impact is measured in all of the patients in Ukraine who have limb amputations, who were impacted by the changes that we were able to introduce systemically. That's our main approach. Another thing too is that I wanted to add, it's too far, that I wanted to add to the previous topic about the complexity of trauma, right? Is that some traumatic amputations are very complex. They are so complex, especially due to tourniquet syndrome. You've seen the prevalence of that is around 40% now, between 30 and 40%, that those amputations are very high-level amputations. And those patients may never be able to be ambulators. They will never be able to effectively use prostheses. And here comes an ethical component, yes, and a component of human dignity too, where a professional, a true professional, should be able to find a way to say no to a patient rather than give a false hope. Because standing on stubbies for 15 minutes is not being a prosthetic user. So if you can shoot a quick video of a person walking on stubbies for 15 minutes, it doesn't mean that that person will be a successful prosthetic user and will actually benefit from that approach. Many professionals who work with war amputees in Great Britain and in the US, including Walter Reed and the DMRC Center in Great Britain, they say that it's better to start working with the patient off the bat on becoming an effective wheelchair user rather than giving the patient a false hope. This is why I asked VASYL about mental health at the very beginning, because that's part of the ethical approach and a very psychological type of issue that exists today. Thank you.
And I totally agree with the issues of the tourniquet syndrome. You're left with a very high amputation of the femur and of the humerus, but we now have intraosseous prostheses. What is the status of the intraosseous prosthesis in Ukraine at the moment?
Who's that question for?
Does anybody have any? Well, I think that for the patients who have a amputation related to a tourniquet syndrome, they are left with a very, very short residual limbs. This is the best indication for an intraosseous prosthesis.
Oh, you mean osseointegration, right?
Osseous integration.
Yeah. I can speak to that. If
you can speak to that as well.
Okay with that?
All right.
I'll be quick. Osseointegration has been used in Ukraine, yep, yes. However, and the government of Ukraine, the Ministry of Health, has now introduced the regulation for the approach. However, that approach still needs a lot of support from external experts to ensure that that approach is applied strategically and effectively rather than like a Wild West type of approach.
And that's a comment that I completely agree with. And if it is to be done, it should be done in centers of excellence with people who are understanding the procedure. It's very technically challenging, and they're very expensive. So, does anybody have any experience with immediate post-operative prosthesis fitting? Because this is a technique that I've used in my practice so that when an amputation is done, especially lower extremity, I, along with my prosthetist, will put a temporary prosthesis on them in the operating room so that they wake up with 2 feet under the sheets, all right? This is not something that's radically new. This was developed by a Polish surgeon by the name of Weiss back in 1947, and it was picked up in the United States. But the advantage of this, now you also use it for an upper extremity, is that the patient gets up and walking the next day. Weight bearing, just touch weight bearing on the thing, and that cast is changed every week. So as the limb shrinks down, with our goal being at the end of a month, the patient will be in a temporary prosthesis made out of fiberglass and plaster and the normal components, but be able to stand up with a temporary prosthesis that they can take on and off. The wound is healed, and their full weight bearing is tolerated. And so, and that is, I think, something that we're not taking enough of an advantage of in Ukraine. What it requires, though, is that there is close coordination and communication between the surgeon and the prosthetist. On one of my trips when I was in Dnipro, at Mechnikova, I asked the surgeons there, where's the prosthetics? And they said, they all left Dnipro at the beginning of the war. I went, really? There's nobody in Dnipro, big city, that's doing prosthetics? He says, yeah. So then I went over to Hospital 16 and talked with another surgeon and says, oh yeah, they're right across the street there. So there's a lot of communication about this. And you know, in the United States Army in World War II, we had a couple of specialized centers for amputees. It was Walter Reed, and there was West Coast as well. In Vietnam, we had our Amputee Center of Excellence at Valley Forge. So everybody in the military who had an amputation went there. There's support among each other. They challenge each other with this. And then in Iraq, Afghanistan, we had Walter Reed, San Antonio, and San Diego were the centers of excellence for this. And I think there's benefits of being able to have these types of activities centralized, especially for the military, because you want to get them up and move. I've always told my amputee patients, you're not disabled. You're differently abled. But and I don't give them a parking pass so they can go park close. I make them walk, all right? I make them walk, and that's good.
Since we're in the panel, I want to add something to that. I do agree about the centers of excellence, but I also want to add that it's important that those centers of excellence are not just repaired, fancy facilities and walls and equipment.
Oh.
It has to be, first of all, qualified people, qualified staff, qualified professionals. It doesn't matter how many square meters a building is, doesn't matter what type of lighting there is in the building. What matters is who works with the patient and what type of services they can provide.
Well, and I completely agree with this, because in Lviv at Unbroken, St. Panteleimon, First Medical Union, they moved the prosthetics center 5 miles down the road.
No, one mile.
No, it's longer than 1 mile, because I've traveled that road. Well, it depends on where you come out of the hospital, but it's not in the same place. And to get the prosthetist back and forth is difficult communication. So my thing is that when I have a patient who's going to undergo an amputation, I send them to my prosthetist to begin with, or or somebody with a motor. You know, we don't have the trauma in the United States that you see in Ukraine. completely different. But what I'll do is that there's a patient often with motorcycle accident, gunshot wounds, and there's an unsalvageable leg, I will have my prosthetist come and talk with them ahead of time, right? Or if it's an outpatient and they're going to have a scheduled amputation, I send them to my prosthetist so they can talk with the people, and often then they get another patient, same age, same sex, to talk with them about what life as an amputee is. And then they will come back and generally say, let's get on with this, I'm ready to move on with my life. So anyway, David, getting back to you.
Yeah, and again, I apologize for
Oh,
the delay. I'll just, again, just appreciate the opportunity to participate. I am away, so some of this hopefully will come through clearly. It's a lot easier if I had to just cross the Charles River to be there in person. So I appreciate everybody's effort, and for the part of the talk I heard earlier, I really appreciate everyone's comments. I'll just say from the perspective as a physical medicine rehab physician, I mean, I run the amputee program in Boston, and I think the idea that I would like to just bring to the conversation, which is brought out, is the actual benefit and goal to strive for improved multidisciplinary care. And when I use the word multidisciplinary care, it involves not only the surgical team, but a physiatrist, physical medicine rehab physician, in addition to therapists and psychologists and nurses, and of course the prosthetist. When we created the interdisciplinary ICANN clinic at the Mass General now close on 10 years ago, it was with the idea to bring state-of-the-art care to the patient when the patient needs it. And that sometimes involves pre-surgical consultation, post-surgical consultation, and of course, I think it's already been mentioned clearly, the role for longitudinal care. So providing a prosthesis without a plan for ongoing management, the changes will need to be made, the anatomical changes within the patient's activities change, their desires change. So this has to be a multidisciplinary process, but also based on, I think someone it was in maybe one of the movies. We think of amputee care as a marathon, obviously with the Boston Marathon as our backdrop. So I'll mute off for comments for that.
Thank you, David. I think Jared also had his hand raised, and thank you for your patience, Jared. Go ahead.
Yeah. Oh, it's totally fine. It's great to be with this group. And to be honest, I've really appreciated the talks that have been given before. I think it's nice to get some strong data behind this. It's one of the challenges in any conflict and in just in any scenario where you're working with rehabilitation patients is to have good data backing up, the future direction. So I wanted to second a lot of the things that have been said about building long-term rehabilitation teams. So thank you, David, for bringing that up. I think that's a critical part of this. And I think one of the things that we've seen in our work in Ukraine as well is this opportunity to build multidisciplinary teams that are stronger, not just on the prosthetic side, not just on that, but really engaging with the rehab medicine or the physiatrist as kind of the key quarterback, to use an American football analogy, that's directing and guiding that care. The surgeon obviously is a critical component. The prosthetist is a critical component. But somebody guiding and directing that long-term rehabilitation is a core part of what was established for us in the military hospitals here in the United States, following Iraq and Afghan conflicts as well. And so it's great to hear this. And then the other thing that I'd like to comment on is the power of education, the power of training. So kudos to the Protez Hub group, significant kudos to that, and just in terms of building long-term sustainability in any region. And where we've worked in many, many countries of the world providing prosthetic care, that's the one thing that oftentimes is lacking in terms of long-term preparation. So I wanted to give kudos to that and also discuss that a little bit more. And not to steer the discussion in a different direction, but one of the things I also wanted to speak about was just enablement with technology. And so I wanted to get the perspective of the other panelists on how do we enable technologies? How do we use this opportunity to both not only establish a baseline level of care that's consistent, but establish a level of care that actually might supersede care that's provided in other parts of the world? One of the things that we're particularly interested in, as a simple example, is additive manufacturing and how to produce quicker, cheaper, better prosthetic sockets that are both performing on a higher level, at a lower cost, at a faster speed. And so I wanted to talk a little bit about that, or at least ask for comments from other panelists as well.
Well, I'll just
Sure.
jump in and just.
I'm happy
Oh,
to comment
go
on
ahead.
that. Yes, 3D manufacturing is part of Ukraine's reality right now. And there were a lot of attempts to introduce different types of 3D technologies in Ukraine. Many of them failed. Why do you think they failed? Because it was
I have a lot of personal experience with this. So.
Because
A
it
lot
was
of it
poor
is,
3D technology that was introduced. Ukraine is often being used as a testing ground for a lot of not quality things right now. And they, one of my colleagues that we regularly work with together, Anton Johansson, who's he's part of ISPO, and he's also the clinical manager of OSER. One phrase that he said once to me now resonates with me every time we talk about new technologies. If you would never try it in your own country or do it in your own country, do not do it in Ukraine. So that's the key message in terms of introduction of the new technologies in Ukraine. If it has been tested, if it has withstood the ISO criteria, all of those other things that are in place already, by all means, please introduce it in Ukraine, and Ukrainians will try it and see if it fits the needs. If it doesn't fit their need, don't push it on them. Thank you.
VASYL?
May I add some? If you talk about 3D printers, I think that in Ukraine we have a number of 3D printers. We have like 3D laboratories in Lviv that is maybe the hugest in Europe. One laboratories can produce such number sockets that can cover all Ukraine's need. So we don't need additional 3D printers in Ukraine. And but if you talk about some like efficiency, financial efficiency, about cheaper, we should understand that this is like market, because government through the Ministry of Social Policy paid for the prosthesis. It pay more than 100 enterprises try to compete for this. And if you talk about cheaper, they are responsible for how it's cost, and his interest is to make this cheaper. But in other side, patient want to the best prosthesis in the world, from Orthotics and etc. And we cannot provide our patients some handmade prosthesis because they can know
But you also have to fit the prosthesis to the patient and what the patient does. If you have somebody who's a manual laborer and fitting them with a very high-tech myoelectric prosthesis, that probably has a chance of not holding up over time, and they're very expensive to fit. And the other problem is that limbs change over time. You have a limb that you fit initially, and that limb is going to change, whether patient weight changes, their muscular development changes. All these limbs continue to change over time. And I think manufactured computerized systems really need to be looked, because there's an art to this as well as a science. So do we have questions from the audience?
I think David wants to comment.
Oh, sorry.
Okay, David, go ahead and comment. While you do that, I'm going to find a question in the
Again,
audience.
I just wanted to sort of the pivot and the idea of using high tech, which has its place, but I think the real emphasis, and I think one of the real key messages, is that high tech is okay, but what we need is high touch. We need high touch, we need high quality trained physical and occupational therapists who work as part of multidisciplinary teams that can help people use technology, whether it's body powered, myoelectric, 3D printed, or what have you, but they need the training and the expertise. I think the key is that early rehabilitation, that early prosthetic rehabilitation will lead to early success, early adoption, and that will lead to greater use and less down the road of people beginning having difficulties, lower level of difficulties, but also keep their, be able to use their prosthesis. So I would emphasize on the high touch of both physical and rehabilitation therapists to excel at prosthetic rehabilitation.
I have a
May I-
question.
Okay.
Go ahead.
I want to continue. If you talk, yes, we need additional training in physical rehabilitation medicine, and we have 7 centers of excellence for rehab medicine, in which we concentrate and gather international expertise. And the teams, multidisciplinary teams around Ukraine, give the trains in this our center of excellence. So if you are ready to provide some additional training for Ukraine, let's connect us with our center of excellence, because, for example, center of excellence in Dnipro already is the amputee rehab program in the Center of Excellence in Dnipro is certified already UM's PRM, European Medical Specialty PRM boards, accreditation. Yes, and we can add some.
Yeah, so question for you, and I know it's very hard to answer this question, but we are in one of the best institutions in the world, educational institution, and we have a lot of willing participants from other institutions as well, like Baylor, Spalding here at Harvard, and there are many other institutions in the United States who would want to help, and some of them are already helping Ukrainian prosthetic efforts, and obviously the quality of care matters the most. But if you were to give us advice to people in the United States who are trying to help in prosthetics, how would you go about it? I know we're doing this whole conference to make sure that we collaborate and do things together and not disjointly, but I would want to hear from you, Antonina, if you can give us some advice how we can do this better, because it is a little bit of Wild West to me, who is not a prosthetist. I'm a colorectal surgeon, but I'm looking at it from the side, and I want to make sure that we do quality of care in Ukraine.
How long did it take you to become a surgeon? How long? How many years?
20 years.
How long does it take to become a physiotherapist in the U.S.?
4 years of college, and now it's a doctorate degree.
Right, and to become a prosthetist, they need to go through a general biomed or physical therapy bachelor's degree, kinesiology degree, then 2 years of master's, then internship, and then they become a prosthetist orthotist. That's the level, at least roughly, the level of the professionalism and qualifications we're trying to achieve in Ukraine right now through the standards and the launch of masters and everything. Today, if you hear of a new center being established somewhere in Ukraine, regardless of their advertising and promo materials and everything, be 100% sure that that center has prosthetists who were trained for 2 weeks to 3 months. So compare that. And most of new centers that were established in the past, like a year and a half, are like that. That's who works there, and that's who fits patients there. So this is why we're wary of the things, for example, like a center right at the hospital, because you cannot guarantee the quality of care. You have to first make sure that people will not be hurt. A prosthesis can harm a person, not just help a person. It's a medical device. So number one advice, invest in education of professionals, long-term education. If you can support those 4 universities, thank you very much. Technology that is in demand by experienced professionals. I can give you a list of 34, actually it's posted on our website, the list of 34 certified prosthetists. Reach out to them, ask them, would you be using this technology? They'll say yes, no, they'll even explain why. And then you know if it's applicable or not.
So can I ask you, in Ukraine, both from a legal point and practical point, who writes the prescription for the prosthesis? In the United States, it's a physician.
Multidisciplinary team. The doctor, multidisciplinary team.
Who's on the team? The physician?
The PRM doctor,
PRM doctor.
PRM doctor.
physiatrist.
Okay. So physiatrist only, not a orthopedic surgeon.
So,
not a,
hopefully, when we
Careful.
get all the signatures in place, the standard, right? The rehabilitation standard. VASYL was also like so looking forward to this standard. The rehabilitation standard will change that. The one that I spoke the last about,
Okay.
it's all based on outcome measures. The things that are in place in the US and will soon be in place in Ukraine. The person will be properly assessed using AMPRO, AMNOPRO, and all other things. Then the PT, OT, and the physician will work together to prescribe, and the prosthetist, orthotist will then select the components.
Well, that sounds wonderful. It sounds like a good way to end a great session, to make sure that we are taking at least a little bit of time to nourish our bodies before we move on to our other sessions at 1 o'clock. So thank you all for participating, for guiding the session, Hudson. And there will be lunch available for everyone that's complimentary. So please feel free to grab it. We have about a half an hour to consume it and discuss all the hot
Big
topics
hand
that
for
were thrown in.
our panelists.